everyone. My name is Duncan. I'm an assistant professor here at the Department and the Division of Global Health Equity, and it's my honor to introduce Bibhav Acharya, a longtime friend and colleague, currently an assistant professor at UCSF, and one of the co-founders of, along with myself, of Possible in Nepal, which of the work he will speak. He's also recently the founding director of at UCSF of the HEAL Global Mental Health Fellowship, which is a really innovative fellowship that one of the sites is that we're starting is in Nepal. And in addition to that, he is the founder of Shared Minds, which is a really innovative organization dedicated to advancing the teaching and training of mental health in Nepal. In addition to his numerous accomplishments, he's just been a tremendous personal friend over the course of this long journey, and has been a tremendous advocate for Nepal, a country he grew up in, as it emerged from the devastating civil war and fall of monarchy and this new democracy that's brought tremendous opportunities for in so many different aspects of life, but especially in healthcare reform and in health services research, and really taught this group of colleagues from Nepal and other parts of the world a remarkable approach to implementation science, where real services and patients lead the science, and the science follows from that. And so, further ado.
Thank you, Duncan. Actually, brother Duncan. It's been working with you. The pleasure is all mine. It's an honor to be here. Thanks for hosting me. We're going to be. My understanding is that we have. Let me actually look at the clock, so I'm not going for it. My understanding is like about 5 minutes or so of formal presentation, another 30 minutes of questions. Really, we're talking about a program that is sort of underway at our site in Nepal, and I'll present some preliminary data. But the hope doing this is that we can really have a conversation about challenges that we face, the challenges that our patients face and our providers face, actually, and hear sort of other ideas that might work, and we'll share some of the ideas that we've used to address this issue of large burden of mental illness. I don't know conflicts of interest. Fund healthcare services of the program that I'm going to talk about come from Possible, the nonprofit that Duncan started, along with a few others, and government of Nepal. So that's important to remember, that the work that I'm driving is actually based at a public government-owned hospital system that our nonprofit runs in partnership with the Nepali government. The research aspect, the in-country expenses come from the Center for Global Health Delivery in Dubai, and my support comes from my department at UCSF. Things hoping we can focus on today. What are the main challenges and risks that are particularly unique to task sharing in mental health, and how can you address some of these challenges? And then looking at it from the specific lens of the tradition in global health delivery, been paved by HIV, tuberculosis, malaria, maternal child health. What are the things that we can learn from these initiatives, and what are the things that we still need to unlearn? Because mental health is unique in some ways, but similar in others. And I'm hoping that we look at this from that particular lens. The work, and then really get into the risks and challenges, and then hopefully we'll have a discussion afterwards. So let me start giving a sense of where the field is. And we have excellent papers written by people who are in the audience. Anne Becker and Arthur Hyman's first paper describes the state challenges in mental health and the direction that the research needs to go in. And Bibhav and his colleagues, more recent work from DCP, looks at what are the progress that have already been made so far, and what's sort of the direction we need to go in really scaling up these services so we can realize our hope of expanding access to high-quality treatment. Basically, the mental illness is really high around the world. It's been documented over over, it is really high. So people not getting access to high quality care, that's really high as well. The good news, we actually have evidence-based interventions that we know work in lower settings all around the world. So at this point, is how do you scale up the interventions that we know they work? And the way to list up is by essentially taking the interventions out of these tightly controlled randomized controlled trials into the real world. And also making sure that there's political will and financial resources to actually fund the work. So that's where the field is, right? So we have interventions, now it's a matter of scaling up and getting the political will and the financial resources. And this is where work comes in. So as Duncan, work is in Nepal, which is a small country sandwiched between India and China. 30 people with a per capita GNI of 730, which makes it a low-income country. And start by talking briefly about the patient that I saw. This is a 16-year-old boy that I saw a few years ago, living in rural Nepal, and he's from a Dalit family, which in the Nepali and Indian South Asian caste system is at sort of the lowest caste, historically disenfranchised. And this was actually at the top of his school when he was doing well. So you have an extremely impoverished family from a low caste who has this brilliant young child who has this promise of really accessing access opportunities that can even bring the family out of poverty. And about 3 months before I saw him, he started to go downhill. So his school was going down, and then he started to sort of talk to himself, and then not sleeping well, started talking, and the behavior became difficult to control. So he damaged neighbors' properties, and it's a very poor family, so they had to take out loans to pay for the damages he was doing. Took him to a traditional healers, which is quite common. Patients are taken to traditional healers before they come to us, and but unfortunately he did not get better. So in desperation, the family had him up in a fetal position for 2 weeks straight. That's how he was sleeping, that's how he was eating, that's how he was toileting, because of how well to control his behavior, and he was causing damage to property, people, and that was saying, not property, but also the family, because they were slipping further and further into debt. They untied his legs and only tied his arms so that he could walk the 3 hours it takes to come to our hospital. So this is to see him. When I saw him, you could not even communicate properly with him. His mind was just completely jumbled up and completely disorganized. So obviously factors go into how a brilliant kid within 3 months ends up tied up in a fetal position for 2 weeks. But there are broader there are factors at play. So let's look at some of the broader factors. Just most low and middle income countries, Nepal spends less than 1% of its care budget in mental health. So it's about 0.7%. Again, just like most low income countries, most of that money goes into a solo mental health hospital capital. So 60% of the money actually goes to this one hospital. There are 50 psychiatrists for 30 million people, and about 12 psychologists, again, for 30 million people. And national numbers, so the further away you go from city centers, the issue gets worse and worse. So we are in a region, you look at the whole region, 5 to 6 million people do not have a single psychiatrist. And again, unfortunately, it's quite typical of many low-income countries. So when you look at context, it's no surprise that this would happen, that someone would have to be tied up and not get treatment because the resources just not in, although we know how to treat this, we know how to help this person. Move now to talk more specifically about our site. So this is a town which is where we started working about 10 years ago. It's an external site. The nearest airport is about 10 hours away. Then full-time psychiatrist is about 14 hours away. And before Organization Possible went in, a region of about 250,000 people did not have a single physician. Not a psychiatrist, just a general physician. So highly under-resourced. And over the last 2 years almost, we expanded our model to the second site in Psychiatry after the earthquake in Nepal in 2015. The government invited us to essentially replicate the model that we have been implementing in our first site in the town. So these healthcare systems, I'm just showing you the buildings, but this also includes a network of community health work around the district level hospitals. both mental hospitals, and have a private clinic staffed by about 20 physician and non-physician primary care providers. And this is where we're implementing the mental health program. So is it clear in terms of the strains and sort of the world settings that we're trying to test out a mental health intervention that's evidence-based to see how it fares in sort of this real setting in a primary care system. So to orient ourselves, we finished talking about just the context of the work, and now we'll get into more of the risks and challenges. Any heard of the term task shifting or task sharing? All right, everyone heard? That's great. So, it's been in various ways across various disciplines, but perhaps the in terms of organizing it and studying it really came from HIV, and then also in tuberculosis and other infectious diseases. The idea being doesn't really need all the work. You can have non-specialists, locally trained, who can provide expand access to care. Using people do this. So using the idea of task sharing and based on the collaborative care model, which was perfected in the University of Washington, part of the impact, we came up with this model to implement mental health care at the site that I mentioned in a general primary care clinic. So let me just walk through what happens with a patient. So a patient generally is seen by a primary care provider. So I'm going to use PCP when I talk about them. These are doctors or health assistants who are similar to a physician associate or nurse practitioner in the U.S. And in the world, you'll find a lot of these non-medical, non-MD, non-physician primary care providers. So they evaluate the patient, and if they suspect that they have a mental illness, they send them to a psychosocial counselor. Again, you can call it various names, right? So some people in the U.S. usually have a social worker in this role, or an RN who has mental health training. So someone has a behavioral health background and expertise will evaluate the patient and do a full evaluation. Because usually these doctors are unfortunately spending about 3 to 4 minutes per patient doing evaluations and seeing hundreds of patients at a time. So counselors generally have more time, and you need a lot of time to really figure out what's going on, and then work together to come up with a plan for the patient. And the consultant psychiatrist is actually off-site. This person's based in Kathmandu. Sometimes they travel. He goes to China for part of his fellowship. No matter where he is, he's off-site. But he calls in every week to review all the cases with the counselor. And then quarter he comes in to provide on-site training, supervision, so he can watch the physicians assess patients and deliver care and give feedback. And fortunately, we have community health workers, something I miss dearly when I practice in San Francisco. And health workers, I'm sure all of you have them, they're a lot more available in low-income countries around the world, and they help with monitoring adherence and helping patients come to the hospital early and poorly, and finding patients who may not have known, or families who may not have known to seek care. So this is the general sort of framework that we're using to deliver mental health care. Questions so far, just in terms of understanding the basics of setting the scene. I hope you're comfortable asking questions. All right, here, people ask. Excellent. So I'll quickly show some preliminary results. I really want to spend most of our time talking about our experience and the risks and challenges. We're mainly looking at depression at this point. So for the patients that we enrolled in the first 3 months, we're looking at 15 patients. PHQ is a questionnaire that's validated in Nepal. It's very commonly used around the world to assess depression and also monitor how the patient's doing through time. So when you have a line of about 15 PHQ, that means this is sort of a moderate to severe range of depressed population. And then seeing a 6-point drop is actually quite significant. This is translating to about 40% in clinical response, which is defined, this is one definition, a 50% decrease from your baseline. So whatever you came up with, if there's a 50% decrease in your PHQ-9, that's considered a clinically appropriate response. And because this number, this ends up comparing to the randomized controlled trial that I talked about, the IMPACT trial that was done in Seattle, which developed a collaborative care model. So preliminary, this is good. The follow-up rates are still pretty good. And again, we've sort of completed the first year of the study, and we have one more year to go. We have better data soon, but so far this looks pretty good. That even in an incredibly remote region with an off-site psychiatrist, we are able to deliver different care and sort of get the kind of results people are getting in a highly controlled, well-resourced randomized controlled trial in Seattle. So to organize some of the challenges is to look at the healthcare delivery continuum. And again, there's diversity in the audience, so please interrupt me if I end up becoming too clinical and it's just not making any sense, because the purpose here is for you to learn, not for me to talk about things that make no sense to anyone else. Right? Just interrupt me. Look at the healthcare delivery continuum. First, you need to identify the patients that you want to treat, and you diagnose them. So you screen them with identification, and then you diagnose them formally, and then you start treatment and maintain. It's pretty straightforward. So you got 4 pieces as the patient travels along the healthcare continuum. So what I'll do next is I'll take one of these pieces one at a time and talk about some of the specific challenges that we've encountered, and also talk about what we have done to address some of these challenges that are more specific to mental health compared to other disciplines. So this is he's a health assistant, the sort of the MD PCV that I mentioned earlier, and this is part of our training. We're training people using sort of the standardized patients, asking providers to interview them and evaluate them, and think whether they have depression or some other illness. So when now, what I'll do is I'll try to sort of talk about how a lot of providers have been conditioned in thinking about delivering healthcare, and a lot of this comes from experiences in HIV, like I said. So generally, what you do is you train people saying these are their common presenting symptoms, or this is sort of a high-risk population that you need to do screening for, right? And then the person to do an HIV test, it comes out positive, you're good, you made the diagnosis. And generally, someone in the clinic who receives a little bit more training, advanced training in HIV, generalist, not a specialist like Dunbar, right? The generalist who really wants to focus, who wants to develop their HIV skills, and they take over the care of the patient. And that sort of works quite well, because now you've sort of handed over the patient, and this person has expertise, and they'll take over. We sort of used that model before this iteration. We sort of used that model. We used as sort of our mental health person. I ran into a couple of problems. First, the burden of mental illness is so high that if we have one designated person in the primary care system, that person very quickly gets on. I am the host. Can I crowd? No? Yeah, yeah. Right, so the first problem we ran into is that he got overwhelmed very quickly, because people would screen and then send it to, and then evaluations take time, maybe 15 patients a day, which is quite a lot. 15 new evaluations, that would be a lot. But there, people are looking at him and saying, "Why are you so slow?" Because I'm going through 50 patients, and you're only looking at 15. So that's the first one. But the other problem that, again, this is not new. This is something that's been talked about in the literature quite a lot. But the other problem that became very confusing, both patients and providers, is that the patient concern, what the patient cares about when they're coming to see you, doesn't always match what the guidelines say are the diagnostic criteria. So here's what I mean. Depression, for instance. The most common presenting complaint for depression. Any guesses? Fatigue. We're gonna say? Yeah. Any other guesses? I know you're good. I'm playing mind games. I know I'm a psychiatrist.
Non-physician in the room. So.
Yeah. So abdominal pain, fatigue, right? It's a lot of somatic complaints. And even in the U.S., when you look at, there was a really interesting study. They looked at patients who were in a psychiatric clinic with the formal diagnosis of depression, and they tracked them through time and looked at their initial presenting complaint. 72% of them had actually presented pain. And this is in populations. There used to be this thought that somatic complaints are mainly seen only in non-Western populations and not so much in Western populations. And that's not entirely true, and what seems to be more true, is if you have a setting where mental health is stigmatized and there's no access to mental health, patients are going to show up with somatic complaints. That's how you get access. So that's how you train the population to sort of get access to care, by really prioritizing somatic complaints. So you have patients coming in with abdominal pain and fatigue, and then he would look at his MH-GAP, which is sort of his WHO protocol, and then it would see yes, fatigue or abdominal pain or all these somatic complaints could be the presenting symptoms, but the diagnostic criteria for depression. And they're completely different. And what is people will get into this power struggle with the patient saying, you have depression, this is what your real problem is, and the patient saying, I am tired, or the patient saying, I have, abdominal pain, I have ring in my ears, I'm feeling dizzy all the time, or like I have joint pain. And that mismatch ended up causing unnecessary power struggle, and I think is a little bit different from others, which again, you present with diarrhea, whatever, some kind of acute infection or HIV, and it may not be something that the patient was expecting, but you don't usually see the same kind of power struggle. The clinicians are quite comfortable explaining why HIV was causing all these things. But when you come on, depression is making you have abdominal pain, it's a lot harder for patients to hear that and make sense of it, which makes sense. Like if someone told me the same thing, I'd be quite upset. And other problem as a consequence of this is that because people are used to saying, I'm diagnosing you and I'm going to hand you over to this HIV person, when they say the same thing for people who have abdominal pain and all these somatic complaints, getting upset. Because they're saying, I came in because I have these pains, and now you've sort of dumped me to see this counselor who examined me, who doesn't do any tests, and people were upset, so they didn't really want to go see the counselor, right? Which, again, this is something I feel we need to unlearn from some of these other sort of specialized task sharing healthcare delivery systems. So it sounds pretty straightforward, like co-management. And what's more important is what not to do. You don't want to say, now that you have depression, now you're someone else's problem. The care provider still needs to keep seeing the patient, especially the ones who come with somatic complaints, because that's what they care about. That's what they think is important for them. That's what's causing disability. As opposed to saying, now that I know you have depression, you're not my problem, I'm going to hand you over to the psychosocial counselor. This is one of the counselors at our site. So let's talk about the second part. So the second part in the healthcare continuum in terms of diagnosis. And large challenge comes up with the fact that unlike HIV and tuberculosis and other, or pregnancy, we don't have a test that is quite objective and sort of is based on laboratory or imaging diagnostics, right? So our tests are based on sitting down with the patient, listening to their story, hearing their life story, and hearing the story of the people around them, and try to make sense of what could be going on. Again, this is often used as an excuse for inaction, that because it's so hard to diagnose, we should not do anything, mental health is too complex. And this is definitely past that. The public maybe not completely, but things are a lot better now that we're able to diagnose for sure, just not at the same level of fidelity as like an HIV test, right? Now, when someone comes in to my office in San Francisco as a practicing psychiatrist, they have usually been seen by a primary care provider before they come in, right? And has usually run some tests and an exam, ruled out something else that could look like depression, and then refer them to a psychiatrist. And then someone at our clinic does an intake again to rule out nothing else could be going on and make sure there's a mental illness. So when a patient comes into my clinic, the pretestability of having a mental illness is really, really high. Does that make sense? A lot have already been ruled out by people who come before me. So when I say that this person has depression, I'm much more likely to be right, because even before I talk to them, their likelihood of having a mental illness is very high because things have been ruled out. Now, you go out and do sort of community-based screening, for instance, door-to-door screening using a PHQ-9 screen, just the way you would with like an HIV test, you run into a lot of problems because the pretest probability of someone having mental illness when you do door-to-door testing is actually much lower than someone coming in, sick. And because our diagnostic skills are sort of based on, our diagnostic capacity is based on interpersonal skills, if you don't have the same kind of ability, you can run into some kind of, few problems. The first problem is not able to rule out medical mimics, so things like hypothyroidism that like depression or vitamin D deficiency, or even even HIV, anemia. A lot of things look like depression, but they're not. And if you treat them as depression, the patient is actually not getting better. And part of the challenge is that the structure in a lot of these cases is just does not have the capacity to actually rule out these medical mimics like hypothyroidism. So if you want a thyroid test in the file, you may just not be able to. So what do? You say, this looks like depression, I'm just going to start an antidepressant. I don't know whether the person has hypothyroidism or not. And actually say, I'm just going to start a medication if they're comfortable clinically, right? But the problem still remains that not being able to rule out medical mimics is a challenge. The other challenge is not being able to rule out sadness and grief and loss and sort of a normal reaction from depression. Again, I want to make that for far too long, this has been used as an excuse for inaction. We can address this. We don't have to say, oh, this is too complicated and throw our hands in the air and just, treat things that we have a lab test for. But this is an important concern. What we've been able to do, and this is something, again, looking at HIV, strengthening the primary care system really needs to be part of mental health task sharing in my mind. At the HIV initiatives, there was this whole thing about vertical versus horizontal. People have heard of that, talking about some nods. All right, let me just quickly explain this. So the idea was a horizontal care system is sort of this primary care system, much more comprehensive, that should be able to take care of multiple illnesses, right? And the system that comes in that does tuberculosis treatment. So the one-off, I'm going to focus on one particular illness. Actually, a lot of the HIV projects were like that. They would come in and really focus just on HIV. And it became clear that if you're not strengthening the overall primary care system, then your vertical program is actually not going to work quite well. Here, Frank then talked about this diagonal system. People have heard of it, which is like a metaphorical merger between a vertical system and a horizontal system, where you strengthen the primary care system, but you also add specific specialty services like HIV or mental health, right? I think HIV actually took a little bit of time to come to the realization that part of their mandate really needs to be strengthening the primary care system. And when we started doing our work in mental health, it took a little bit of time to have the same realization as well, that if you integrate mental health into a weak primary care system, it is going to fail. And the real world, like in a tightly controlled study, you can actually account for that by bringing in resources. The real world, if you have a weak primary care system, that's not able to document patients, that's not able to monitor them through time, that's not able to find if they're lost to follow-up, and be able to rule out these medical mimics, then your problems, then your outcomes are not going to be as good. Again, which is unique to mental health, the importance of actually supervising the process of diagnosis making when you actually task share with someone with less level of expertise. With HIV tuberculosis, you don't really need to supervise the test. So there's a small percent of people who have false positives, but a lab test is a lab test for the most part, right? Here, how U9 is actually administered has a huge impact on whether the person is going to be diagnosed with depression or not. So when a psychiatrist goes in, we actually have them watch the provide care. There's a huge pull for providers to say, I have this complex patient, why don't you just see them, right? Which is how psychiatrists or specialists end up operating. But when our psychiatrist visits, we tell them, do not see patients, and if you do see patients, you have to see them with a primary care provider, so that you build counselors, so that you build their diagnostic skills, their interpersonal skills, their patient-centeredness, all these things that affect whether the person has the right diagnosis or not. The other that I do quite routinely in mental health is that I change the person's diagnosis. And this is normal. As a psychiatrist, I look at Beppy and Vikram and maybe there is that, it's quite normal that a person comes in and you think that they have depression, and anything else comes up, or a family member shows up in the next visit and they say, they didn't tell you that they hear voices all the time, and they're like, oh, this is actually psychosis, and I do that. So you got to revisit the diagnosis, right? Or someone come in and they say, oh, she has nightmares all the time, and she has a horrible trauma when she was a child, and it could be depression, but it's also PTSD. So revisiting diagnosis, again, this would not necessarily happen in some of the other mental health interventions, and that's a frame shift that we had to do with our clinicians. That now you have someone who's got HIV, that's it. You don't have to worry about them. Put them on the pathway to getting HIV treatment. With diagnosis can actually change, and being able to revisit them through time is actually quite critical. So you start one on depression with antidepressants, and they become manic, and now the diagnosis is bipolar. It's no longer just depression. And time, just emphasizing the importance of co-management, because someone may present with somatic complaints, and you may say, all right, I did my physical exam, I did my tests, and this looks like I can't find a cause, so this looks like depression, but then it could show up later on, and then it could be a medical mimic that you had missed early on. So it's really important to not have this sort of, I'm going to dump the patient onto the mental health program, and really continue to co-manage, so the patient continues to have follow-up appointments with private providers and also with counselors. And make sure we're doing okay. So Bibhav, he's another counselor at our site, in a patient. So now we're at the third step of initiating treatment. Any questions before I move on? No? All right. Did I put anyone to sleep yet? Almost. All right. This is a challenge. Meds are just more available than therapy. And a provider here would really agree, the U.S., right? It's much easier to prescribe medications than get patients access to therapy. It cannot be used as an excuse for inaction, but it is a real challenge. When you look at protocols, US, UK, WHO, whatever, they will always say, especially for mild to moderate illnesses, make that you offer therapy first, right? You see the protocol, and say, oh, I got to offer therapy. You look around, there are therapists, right? And you know that if you write a prescription for an antidepressant, that actually might get filled, right? So what do you do? Essentially reverting to what's available. And obviously has problems because people end up being medicated unnecessarily. And again, it's not to say that we don't know how to scale up availability of psychotherapeutic techniques in these low resource settings. That evidence is absolutely there. The current Ranner trial that showed just that. But the fact remains that it's a lot easier to haul a truckload of antidepressants than haul a truckload of therapists. Right? It's just harder to scale up, and that's a reality, and it's an important challenge. Point about unknown errors. What I mean by that is a lot of the times when we do task sharing, we also implement supervision. Task sharing without supervision ends up being unethical and resulting in poor quality of care. And Vikram and I are going to talk more about this topic tomorrow at Acharya Labs. But really quickly, what are unknown unknowns is that when you have a supervision system that's sort of dependent on the care provider who just learned how to manage depression, to sort of supervision for difficult cases, you miss out on the errors that the primary care provider does not know that they're making. Right? Does that make sense? I'm going to try. So, we got to be honest. They get training in so many different things all the time. Right? Everyone's in with their project and saying, I want to train you on mental health. I want to train you on this. I want to train you on that. And that's, I think, an important difference between a tightly controlled trial and sort of the real world scale up, that these primary care providers are quite overwhelmed with all these different things they have to learn. So if I teach them how to manage psychosis, and then I say, when you suspect psychosis and you got to start medications, do higher than 2.5 in the first go, and then see how they do of haloperidol, and then see how they do and come back. And then a week later, I look at the chart, and the patient was started on 10 milligrams of haloperidol, way higher than you need. Gives you a lot of side effects, right? The fact that a mistake is quite understandable. Like if you're learning so many different things and you have to manage this huge caseload, you're making mistakes. If the primary care provider is making a mistake, it's really the system's fault for not having enough checks and balances to actually assure quality of care at the end. When you're prescribing the patient. The problem is when your supervision system is based on having their primary care providers say, I don't know how to manage this patient, can you help me out? Psychiatry. This is how a lot of supervision systems are structured. And they will never know to ask about that 10 milligrams because they think they're doing it correctly. So that's what I mean by an unknown unknown. They know that they're making a mistake, so they will not seek supervision. Does that make more sense? The third is on monitoring treatment effectiveness. And again, I keep going back to HIV. It's most for a lot of people. It's receives the most attention and funding in terms of a lot of the sort of single diseases around the world. With HIV, you can monitor treatment, looking at CD4 count and viral loads through time. And that's a pretty good indicator of whether the patient's failing or not before something catastrophic happens, right? With mental health, larger trials will use things like PHQ-9 and other similar scales. But you go to the real world and try to implement this, people will that's just too cumbersome. Let's set up to sort of have this person, administer this test, and then where is it going to go? Because like a lot of cases I'm sure you've seen, a patient comes in and the doctor scribbles something in a piece of paper and gives that paper to the patient. So you got nothing left, except maybe like the name of the patient and the age and maybe the diagnosis. That's all the records that you have, and then expect someone to do a PHQ-9 and like somehow save it somewhere so that the patient can, so that you can track how they do over time. And I think again this goes back to strengthening the primary care system, improving documentation, and having the personnel who can actually do the PHQ-9 scores. But if we do not monitor treatment effectiveness, we know whether the patient is doing well or not. It's unfortunate to see quite routinely when I go to Nepal and I'm shadowing a psychiatrist in Kathmandu, and they will do a follow-up visit, and then they ask the family member, not even the patient, how are you doing? Doing well. All right, sounds good. That level of monitoring whether the treatment is effective or not. When that happens, treatment does not get optimized, right? The challenge is a lot of people's expectations about mental health improvement is quite low. So they expect that patients are going to do very well. So they may say, yeah, they're doing well because their expectations are really low. But unless you actually actively monitor how they're doing, you will not be optimizing their treatment. So introduce therapists as much as possible. Again, it's actually possible to do this, and a lot of the times it ends up becoming about intent and political will. Other some of the challenges we faced when we introduced our therapists. A lot of them never worked with a therapist. That's an important concern. So if you're just a nurse into a healthcare delivery system, the doctors actually know how to work with a nurse because they have worked with nurses throughout all training. So they know sort of what their job is, what the nurse job is, and the team dynamic flows quite well. You introduce a therapist, what they're supposed to do. So a person comes in and with multiple somatic complaints and they go to the therapist, and the therapist said, you never actually ruled out all these other things, and the medical doctor says, I didn't realize I was supposed to do that. So a lot of sort of who's supposed to do what really needs to be figured out. And the other thing that's actually quite challenging to do is supervising the therapist, which ends up being a lot more resource intensive than supervising whether someone's getting the correct dose of the medication. You can do that remotely. You can do that by looking at an Excel sheet. Whether a person's providing therapy accurately, it's a lot more resource intensive. So that you can get into the conversation, look at the nonverbal cues. So that is actually an important challenge, and we're trying to address that in a couple of different ways, and I'm happy to talk about that if there's interest in that. In addressing unknown errors, what we recommend is proactive supervision. What I mean by this is instead of waiting for the primary care provider to challenge, the psychiatrist actually says, tell me about all the patients that you saw over the last week. Proactive, in which you actually say, you may not that you need supervision, but I'm gonna talk to you about all the patients so that I can catch some of these errors, like prescribing 10 milligrams of haloperidol when you should really be doing 2.5 or 5 at most. Using the tools, like I said, like the PHQ-9s to monitor treatment effectiveness through time. Community health worker, like I said, I miss having community health workers. I have a patient right now whom I would love for a community health worker to go visit. And unfortunately, they need to come see me, and it's a lot more expensive to come see me than having a community health worker see them. So hopefully, we can bring it to the U.S. And people are trying it in different settings, but certainly not as widespread as it is in Nepal or other countries. So finally, last piece about maintaining. When you start someone on treatment, most of these illnesses are chronic. How do you maintain them? The challenge making sure patients are taking their medications, coming back to follow-up, both therapy and primary care providers. What that we saw with community health workers who had been trained for counseling or adherence counseling in HIV and tuberculosis is that they were very used to saying things like, if you don't take this medication, I'm not supposed to say this, but this is what they do. If you take this medication, you could die. Training, you're not supposed to say that because you don't want to use sort of fear as a way to motivate someone for behavior change. You want to use positive reinforcement, but you know that that's what they say when they're desperate. They're like, listen, if you don't take this medication, you'll die. And that would be absolutely right for tuberculosis and HIV. It may be right for some cases, of course, of depression and even psychosis, for people who are suicidal. For the vast majority of our patients, the burden is actually disability rather than morbidity in terms of compared with infectious diseases. So we really had to retrain our community health workers in conducting adherence counseling when you can't say, hey, if you don't take this medication, you're going to feel really sick or you're going to die soon. And this is true for a lot of chronic diseases, right? It's not unique to mental health. Diabetes is the same way, hypertension is the same way. It sort of feel okay. Why am I still taking this medication? Thing that came up quite often was a lot of patients were seeking traditional healing. And again, this is not unique to mental health as well. I do feel like, again, anecdotally, people who have mental illness are actually more likely compared to our other patients to seek traditional healing practices. Again, I don't really have data for that, so it's just my understanding when I talk to patients. The trend with traditional healing has been sort of twofold. One, providers telling patients do not see traditional healer because they're quacks, it's a waste of time. They're actually quite expensive, by the way. We sort of have this romanticized view of traditional, but they actually cost money or resources. You gotta bring cattle or chicken or something. Most of the time, it's not free. And then the other problem was traditional healers would sometimes say, my interventions are not working because you're taking medication. So there are patients who stop taking medication. And I'm only the challenges. There's a lot of benefit to traditional healers. There's some challenges and there's some rights issues as well. For the most part, what we have tried to encourage is sort of patient choice. They want to see a traditional healer and they want to come to us and take medications, go to therapy. They should have the right to do both of that. My patients in San Francisco go to traditional healers all the time, right? So patients who are in the country do the same thing. But what we try to train our private providers in is to say, don't make the patient, don't force the patient to choose between one or the other. They'll become desperate and they're most likely just not come back because they don't trust you. So it's just easy for them. How many people have heard of this? Let me just half of people didn't raise their hands. I'm going to do a really quick primer of what this means. MI nerds are going to kill me because they'll say, how dare you explain something this complex in a minute. Now, but yeah, is anything that is meds otherwise X. If you don't do this, otherwise X. Which doesn't really work as well. Motivating starts with what the patient cares about. What's improving. And the goal is to enhance their motivation to improve behaviors. And it's not straightforward, but again, the detail is in what you're not supposed to do. What you're supposed to do is confront people's defenses. And what that is, when someone tells you all these reasons that they can't do something, our instinct is to say, let me fix that for you. And let me know these strategies on how you can overcome all these things that are keeping you from changing behavior. And the hardest part is actually to shut up. And just listen when the patient is telling you what's called sustained talk, meaning they want to sustain the behavior that you don't want them to sustain, but they keep doing it, and you listen and empathize, and that's really hard for people to do. And then when they engage in what's called change talk, and usually talk about, hey, I'd like to X, Y, and Z, and then you're like, you verify that, and that's when you talk, that's when you shine. And MI is very tricky to actually teach. The fact that people who just received training in MI, when you ask them about how low their skill levels are, they will rate themselves very highly. And then when you watch them and using like a scale called Mighty and rate them, the rating is actually quite poor. And just a reality that it's a very counterintuitive way of interacting with someone. And some are actually natural at it, so they do really well. But in learning how to do it, a lot of people will say that they're doing it, but actually, a lot of times they're not doing it. But there's a lot of evidence that it works in terms of relapse prevention and adherence and healthy behavior. Everything from following appointments to sort of agreeing to a plan of what's called inhalation, which is a really effective way to treat depression. So they're saying something like, I'm going to spend at least 1 hour every day out of bed, out of my house, right? So at least committing to that. Things like those can actually be helped with MI. Again, and making sure that the skill assessment of their skill level and the actual skill level actually stays the same. That's really quite tricky to do because it requires supervision. But in terms of effectiveness, it's very effective. And we're at our stages of trying to figure this out. How do we train them and how do we supervise them using labs, our community health workers? And it's quite obvious, and there's some initiatives, studies being done now, with traditional healers and having this sort of collaborative approach. And ABI did this, Tuberculosis did this too, in which you work with them and you say, at a certain point, can you please refer them to us? And we will never say things like never go to a traditional healer. We do harm reduction throughout, and that seems to be sort of quite effective. And unfortunately, we've not been able to, we haven't had a lot of success in really collaborating with them. We have trained our primary care providers not to say things like never go to a traditional healer. All right, so the picture I took. This is an old picture. This is the only road that connects our hospital to the rest of the world. And unfortunately, during the monsoon, they have a slide, and all the people who were passengers end up becoming labor to put a jeep out of the thing. So, as a metaphor for teamwork. To summarize the key recommendations. Team actively supervised task sharing. And the reason I have these qualifiers to just task sharing, hopefully is obvious at this point. It's got to be team. You can't just dump a patient onto a mental health person. The patient needs to be proactive to catch some of these unknown errors that people are inevitably going to make when you train them on so many different things, skills that just learned and you're supposed to use them the next day under little supervision. That took me 3 years to learn. You train them in a week, they're making mistakes for sure. And it's not their fault. You got a system to catch those errors. And one other point I'm going to make here is that I'm guilty of this as much as anyone, and I've talked about this quite a lot. The traditional sort of narrative in mental health goes like this, right? So there's high burden of disease, there's lack of specialists, so task sharing is the only way to fix it. And the batch is from people, are you saying that if you're poor or you happen to live in a place that doesn't have a lot of psychiatrists, now I'm supposed to get this discount mental health, this task sharing, low quality stuff? And there's, there's validity to that criticism. And the reason I want to make that point is that if your sharing is actually truly team-based and has proactive supervision, the outcomes psychiatrist is better than seeing a psychiatrist. And that is there's a team-based, so the patients are actually much more likely to have both their primary, sort of somatic complaints taken care of and their behavioral health concerns taken care of. There's proactive supervision. Someone's catching errors in a way that a psychiatrist, again, we make mistakes. And people are actually monitoring your treatment, and they're more proactive at changing your treatment regimen if you're failing in a way psychiatrists in their expertise may think that I can just tell if the person is doing well or not. So quality of care is actually higher if you have these components in the collaborative care compared to treatment as usual. Validity of your patients. Are you doing identification in the community? Are you looking at hospital-based, facility-based, high-risk patients, clinic-based patients, or tests as good of fidelity? We need to be very careful about knowing the pretest probability of patients coming in. Primary care system is an opportunity to advocate not just for mental health, but also to strengthen the overall primary care system. Monitor treatment effectiveness using scales through time so that patients don't fall through the cracks. Use more interviewing. Again, much harder to do than to say, and hopefully we'll be able to do some of this work in the year or so and support patients. I'm able to thank, if possible, Duncan Maru, my brother and my co-PI for this study. Several people that are part of the research part and also the program role. Maria is my colleague and mentor at UCSF. Shines with the other nonprofit that I mentioned, and the people there have really helped in creating some of the protocols that who is a bilingual, bicultural psychiatrist, and other clinicians. Government, like I said, our system is the government, and they support part of our healthcare delivery costs and the research costs coming from the Center for Health Delivery and Provide. To bring this patient, so this guy, and the people a little bit later, so this is a 16-year-old guy with schizophrenia who was tied up in a fetal position for 2 weeks because the family didn't know what else to do with him. I went back to see him, so he was getting treated in our program. I went back to see him at his home, and he was much better. And I asked him what he'd like to do. And this is something I could not even have a conversation with when I did my first eval. And he said, I love reading. This is the guy who used to be at the top of his class. Why don't you bring a book and we'll read together? So he sat down and read me a passage. And it was amazing that he could do that. And he's so organized. He's able to actually function well. Again, he's not back in school yet. And, hopefully we can help him get there. But, he's not tied up. He's not conscious. He's free. He's actually smiling. He's doing something he loves. I can consent him to an actual picture as opposed to asking his dad, can I take a picture of his hands and saying, okay. And then I asked him the most important cognitive test of our times. I asked him, do you think he is? And he said, like the person with psychosis usually does, very concrete. And I said, can you tell me he is? And he said, it's a picture that you take of yourself with your friends. And I said, selfie together. And he said, yes. Thank you.
Hi, I'm an epidemiologist in the department. I have a question. So those of us that have, we work in a lot of cultures, and within cultures, every culture tends to have its own construct of mental illness that are there. And then, so I'm interested in how well what you see in the map on to your construct, and then whether the traditional healers are treating these constructs that you guys aren't, and if that may be a place of collaboration.
That's a great one, which I'm not going to be able to answer to completion in the next few minutes, but I'll give you my own experience, which I think is what you're asking. About cross-cultural differences and similarities, I mean, people who are much more learned and experienced than myself have done a lot of work in this. The way I think about it is, this is going to sound silly, but bear with me. The way I think about it is the way I think about humor. Sometimes it's across cultures, and sometimes it does not. Right? We're known a culture where humor does not exist. Right? Funny to us may not be funny to someone from a different culture. So if you're looking for differences in humor, you will find plenty of differences in humor. And the field of mental health has suffered because we fixated so much on the differences that we've sort of thrown our hands and said, this is too complex, there's too many differences here, we have no idea, none of the stuff we know here would actually work elsewhere. The flip, if you went out and looked for similarities in humor across cultures, I think you'll be able to find some similarities, right? And again, I'm cultural. I spent the first half of my life in Nepal, the second half here. How to be humorous in both cultures. And obviously there are differences and obviously there are similarities. So that's my framework in terms of how I think about all of this. And again, not using that as an excuse for inaction, but to sort of understand the differences and then get around them. Benefit I have, that our team has in working in Nepal is that this organization called TPO they have branches in multiple countries. They actually do a lot of formative work with cross-cultural psychiatrists and anthropologists who validate a lot of these diagnostic tools and been translated like protocols and interview scripts. It has really helped in creating sort of a bridge language that is culturally valid. Again, there are subcultures within the country and there's some variations there. For the most part, it's a lot more relevant and valid when you speak with a patient using a tool that was developed by cultural anthropologists there. So that has been really helpful. Depression, I think what is quite fundamental is the inability to enjoy things that you used to enjoy in the past. That is actually quite common across the cultures in the U.S. and there that I've seen. Now, things like sandwiches, from couple months ago, things like feeling lonely, being angry, crying, and somatic complaints are actually very commonly part of a lot of people's experiences that are not part of the DSM depression diagnostic criteria. So we used to have these tests, and people would write down what's the criteria for depression, and people kept writing down crying. And then any person with common sense would be like, okay, how could this be wrong? Like, crying depressed makes sense. Like, how can this be wrong? So we had to do this. Yes, we look at the protocols, and we'll teach that, of course. And does not include crying, but then in interaction with the primary care providers, we say, yeah, absolutely. When someone says that they cry all the time, screen that person for depression, and that's something that they care about. They don't want to be crying for no reason, right? So we see that quite often. And this question about what are the things that the traditional healer can sort of address that perhaps the biomedical system is not, it has a lot to do with meaning making. Biomedical system doesn't seem to be as well set up to answer the question of why this is happening to me, which is a question that patients and family members ask all the time, like, why is it happening? We'll come up with some mumbo jumbo about it. It's an interaction with genes and environment. Patient doesn't care. Like, what's happening to me, like me personally. And traditional healers actually do a pretty good job, and with different explanatory system. And again, we lump them together, but there are different types of traditional healers. Some use numerology or astrology. Some use more sort of spirit-based or ancestor-based interventions. And depending on their system, they will come up with an explanation. So they will say, this particular ancestor is trying to speak through you. And that kind of meaning-making actually helps a lot of the patients. But the risk is that it can actually be used to take away your human rights and to further stigmatize the patient. Because now your way of meaning-making is that you are cursed, right? The risk there for sure. Just your risk in biomedicine, I don't think it seems like we're somehow pure. But that's one thing that I found that patients really like, making sense of this happening to me. That was a good job. Okay.
Yeah, so for a wonderful talk. I wondered if we could go back to the sort of the opening gambit around scaling up and what are the challenges of scaling up. And if you could say that you know, it's very convincing to talk about co-management as a way to get patient buy-in. What has been a primary care clinician come in, and does it range from, on the one hand, I know you're giving us something else on our task list, or this is now we can be so much more efficient in addressing all of them.
Absolutely. And in our early iterations, we didn't really do a good job at sort of progressing that, because our mistake, I think, was when you think of competencies that we want the primary care provider to have, we focused on knowledge, because we didn't really know how to diagnose depression. We focused on skills. They didn't know how to prescribe the medicines and deliver therapy. What we failed to address, the third competency, which is sort of a lot more deterministic of all of this, is attitude, how they think about all this, which is what you're about. And as you can imagine, there's a whole range of things, right? So what was, we used qualitative techniques, we focus groups with the primary care provider to get a sense of what do you think about mental illness? How do you think about the idea of taking care of people with mental illness? And there's a whole range. There are some people who are personally affected by it, have family members, and they were like, yes, I want to learn how to do this. I want to train how to do this. I feel like it was a big gap in my medical school training. They were saying that in all of their whole medical school, the only thing that they had to answer to cover competency was list 5 criteria for depression. That's it. They never did an evaluation, so they have mental illness is no different from like a layperson who's mental illness. Some people sort of looked at that and felt inadequate in taking care of their family members, although they were physicians, so they were motivated. That's the easiest one, right? It's quite straightforward. Others said, I think mental illness is very uncommon. I don't know why you're making a big deal, because their mind only severely behaviorally disturbed, then you have a mental illness. So they don't think of a person sort of walking around naked, talking nonsensically. That person's mentally ill. So it's them to estimate what percent of your patient population do you think has mental illness. One person said 50%. One person said 0 to 1%, maybe, right? And that just tells you that there's just a diversity in terms of how they think of it. For that, we have to explain that, there's severe mental illnesses and severe behavioral challenges that anyone can pick up on, but then there's other mental illnesses like depression and anxiety disorders that are much more common, but you're able to tell just by looking at someone, which is how they were thinking about it, right? For them, it was a little bit of sort of educating in terms of how this affects them. There were who thought it was not something that they cared about. And then MI technique, what do you care about? Don't do this and say, no, you have to care about it. It doesn't work, right? So what do you do? So they would say, the reason I came to work here is because the HIV prevalence is really high in this region, which it is in our setting. We want to gain expertise in HIV. All right, so we actually work with that. We can find why is it so important to diagnose someone, screen someone who already has HIV for mental illness, and then treat them. So the short version is, because people have so many different ways of conceptualizing mental illness, we could not use a one-size-fits-all approach, changing their attitude so that they have these ideas that we'd like them to have. It has to be sort of personalized, and still, there are some physicians that we have trouble sort of getting on board, and it's a constant struggle. And what we are able to get to them, at least, is when you have someone with mental illness, why don't you just refer them to someone else, and they're happy to do that at the worst-case scenario. Does that answer your question?
From now.
Yeah.
So that you and others are not going to be describing the same challenges.
Yeah.
So how will we use technology to overcome the challenges which, we're down with these challenges?
Absolutely. So, San Francisco, right? Back here in the valley. A lot of promise, I think, with technology, but there's a lot of hype. And I think the hype comes from people with solutions looking for a problem, because they have a tool, and they can use this, because I know you're struggling with something that sort of my technology sort of helps with, right? And I think unless we, as people who are sort of at the forefront of this, struggling with challenges, complaining about the challenges all the time, I think it's really down to us to be able to say, all right, here's what I'm facing. That actually knows technology better than I do, and so for this challenge, as opposed to the other way around. So that's the general way I think about this. Concretely, there are a few things that we have used. I can talk about that, and then a few things sort of in the pipeline that we're hoping we can use. The supportive care system, which relies heavily on monitoring patients and tracking them over time, that we can use technology for that. So capturing the patient's data, use in a handheld and have patients sort of fill it out when they're waiting, if they're literate, or have a community health worker use an app and sort of interview a patient and sort of enter that information. That really saves the amount of time that they have to spend on site and coming to a facility, cuts down on travel, cuts down on frees up the counselor's time to do counseling rather than filling out these questionnaires. So that's one. And then bringing all that data together in a way that's about like data visualization, right? So you can sort out who are the people who are failing, so you can flag them, and spend most of your time talking about their treatment, so that you can improve their treatment. As opposed to happening now, we just have this ad hoc. Like, I remember this patient is not doing well. We have a long list of 50 patients, and you just go through the first 20, and you run out of steam, and then it's just run the rest of them. Use technology to sort and say things like, let's sort it out by patients who have the largest drop off, or like large increases in the PH9 scores in the last 3 months. Not even an Excel sheet, than on paper. So in terms of decision support, in terms of flagging patients, that can come in. Now, there's some potential for using something more advanced like machine learning and AI, where you can feed a lot of this data, like demographic data, things like initial PhD, things that we don't even know are correlated with poor outcomes, and train the machine through time to look at which of these demographic data correlate with worse outcomes through time. Because as we have longitudinal data, you can actually train them, and then use the machine to help you flag these patients, as opposed to just relying on your instincts in terms of history. That's one other potential application. again, how to do, and there's some complexities around privacy and around overdependence on technology, so the person's, sort of becomes slave to what the computer tells them, which is, you don't want that. The other potential is mobile health. I mean, it's again, very getting a lot of attention right now. Self-time patients actually use mobile apps, and penetration keeps increasing. So there are some studies that show that people can use sort of CBT-informed apps to self-manage their depressive symptoms. So then, the thing that we're trying to do with our community health workers, because smartphone penetration is actually quite poor in our setting, people are not literate, so patient-centered interventions won't really work. Centered interventions won't really work. Community health workers are phone, and we can help them, use that to sort of improve their care. So the thing that we're already doing is using decision support tools adding that into the app, so that when they're interacting with a patient, they will use protocols as opposed to sort of just based on what they remember or the multiple brochures that every new person gives them. So that's one. The other I had sort of quickly mentioned around MI is that this is we're in early stages, so I don't know where this is going to go. Is people using motivational interviewing. We go out into the fields, consent the patient to allow them to record the conversation, and have this person review the transcript and give feedback to improve skills in therapy. Improve skills in therapy, as you know, is so important, right? And not just for psychotherapists, but for like any kind of interaction where behavioral health is the main focus, right? It becomes really important that you're patient-centered, non-judgmental, and all that. Very hard to monitor because you have a specialist kind of follow the, community health worker. So I feel like that's one potential application. And again, if you were to go Silicon Valley 2.0 on that, then you could use to evaluate these transcripts. You can do basic stuff that's language agnostic, like how did the community health worker let the patient speak before interrupting, which is a pretty good indicator. I think PCs in the U.S. was it like 8 seconds or something average. So if you can push that further, that's good. Definitely not MI consistent if you're interrupting the patient in 8 seconds. And then you can use natural language processing, that you can even code some transcript and saying, is the language you're using non-judgmental, is it patient-centered? So that would be the next step, again, being aware of privacy issues. But I'd love to hear your thoughts on this too, because I know I'm passionate about this. Yeah.
Those are, I mean, if you've been able to integrate some useful technology, it's great, and that we try to do that, and we try to do that in different ways and struggle with it. My turn is part of what you're talking about is care coordination within a functional primary care system. Yeah. The problem is that we are siloed off. Even if you have program leaders who support mental health integration, and within the broader system, it's still failed on some level. So something I've been thinking of the idea that there should be care coordination technology that's embedded within the primary care system. Yeah. Beyond health people always scrambling to bring in this cool technology. So I mentioned this meeting, and you will be invited to, but Elner runs the program at Global Prime Social Change, and he's been working really in the private sector and thinking that the only way to transform primary care is through technology in the private sector. So in a primary care meeting, and we're going to have a sort of mental health meeting focused on the things that we talk about. But it was an interesting conversation because the idea was that primary care needs to be fixed also, and then can piggy onto that. Things will become much easier.
Well, that sounds amazing. One thing I would add to that, and this is how we got, just being one of the leaders totally helps. The other sort of on the ground medical directors, the other thing we sort of you sell this work is that adding more and more specialty care to primary care is a challenge that's beyond mental health. Right? With them, you're going to have a lot more patients with diabetes, hypertension, a lot of these cardiovascular diseases, COPD, this stuff is going to get more and more complex and sort of beyond what a primary care provider really needs to be taken care of, right? So there's actually a way, a model to bring a specialty care, coordination, support and quality assurance of the primary care provider's work, and you can use that hopefully for diabetes, or cardiovascular disease, COPD, even cancer, all these other specialties that we need to continue to bring to primary care.
We're talking about sort of health center-based care delivery, which involves the clinician, and then we're talking about community health worker engagement at the household level. Similar but different.
Yes.
And we're having to coordinate these two
Yes.
systems. And I'm worried that we're trying to do too much, and until we figure out the technology piece that is by primary care, we're going to be spinning our wheels the next 10 years.
Absolutely. So that part about community health worker and facility-based coordination, a lot of the studies, when you track them, they're sort of running on their own. You have an excellent community-based study, you have an excellent facility-based study, but how to coordinate this conversation. And so that through technology, it's like when a community enters some data into her app, how does that get transferred to a facility to EHR in a way that's not overwhelming, in a way that actually can be used for treatment planning? That's a huge challenge, and I don't think it's been answered.
I spent the summer working in Bibhav for fall, and we were a part of a program to train skilled birth attendants. One of the issues that we identified, like through program evaluation, was the lack of confidentiality, and a lot of time we'd hear something and you think you're treating social uterine bleeding, she's been bleeding for 3 weeks, and you find out it's like a false abortion or something like that. So I'm wondering if that's an issue that you've noticed with mental health, and if so, how you're addressing that.
The question you bring up, it brings up multiple things around confidentiality, around, what's an acceptable way to access care where something else is actually going on. And this happens in mental health as well. This comes to mind is actually in my mind around domestic violence, which is incredibly common. In our setting, alcohol use among men and perpetrators of domestic violence among women. And when they come for care, it's for something else, right? And a lot of times for mental illness, we get involved when a person comes in with fainting spells. And this is quite common, it's very well documented that in a lot of things where, again, mental health is stigmatized, and women in particular with low education living in rural regions, when they're under trauma, they're a lot more likely to have a fainting spell, often called a conversion disorder or something. Seek care because you were beat up by your husband is just not a thing, right? So if you express that behavior, it doesn't result in care. It's expressing another, again, this is not intentional or conscious, but and some neurological mechanisms behind why someone would have a fainting spell, chill tone. If you're interested, American Journal of Psychiatry has a conference that just came out a couple of weeks ago about Syrian refugee who had fainting spells, and the doctors struggling in this question, like what's really going on here is something completely different from what you think you're treating, because you think you're treating fainting, but what's really going on is like the trauma that so again, that has good resources on that. We see that all the time, and the way we've gone about it is we got to get title, right? So family member or community health worker is usually an amazing resource because usually knows what's going on. Because how much confidentiality village is, it's sort of is helpful because we can get this information that we would not have received from the family otherwise. So we use them to get a sense of what's really going on. Is it violence? Can we do something about it? So they know we're treating the appropriate thing as opposed to whatever is the presenting behavior, which is important, but that can sometimes mask what's really going on behind it. Sure. Anything else?